Today in our urology Viva preparation, we are going to discuss the male LUTS, both medical and surgical treatment. Thank you for the trainee who has agreed to record the proceedings so that it will be a good revision source. Let's dive into the situation. You have a 72-year-old man presenting to your clinic with history of mixed LUTS. How are you going to evaluate?
Yeah, I will see him in a dedicated lower tract LUTS clinic with full bladder for urine analysis, free flow postword residual, and a pre-filled IPSS questionnaire, as well as a bladder diary for a minimum of 3 days. I will take a history to elaborate his lower tract symptoms with the storage, voiding, or mixed. Impact of his quality of life, his fluid intake, in particular the caffeinated beverages, any treatment that he has tried in the past, any red flags such as recurrent UTIs, visible hematuria, pain, and weight loss. And will also assess his expectations, note his comorbidities, in particular, any anticoagulants, any comorbidities which he takes anticoagulants for, and his drug history. I will perform a chaperone physical examination, focusing on his external genitalia, noting if there is any phimosis or meatal stenosis, scrotal pathology, any surgical scar, palpable bladder, and perform a digital rectal examination, note the consistency of his prostate and size, and finish by a focal lower limb neurological examination. Based on the history and examination findings, I will arrange further tests.
Yeah, so sleep apnea, snoring during the sleeping, disturbed sleep, feeling a bit tired in the daytime, they are also equally important because they may be the sign of obstructive sleep apnea, which can result in antidiuretic hormone mismatch. That can also be resulting in patient getting up in the night to pass urine. Okay, the examination shows a 70 cc prostate, no signs of any suspiciousness, no neurological deficit. How are you going to treat him further?
Okay, yeah, I will note his urine analysis and free flow was void residual. Note if he had any previous historical kidney functions test, and just to see if there is any signs of kidney function deterioration. I will note if his IPSS score and bladder diary, which should have been filled before he attended to the clinic. And I will also, given he is 72 years old with lower tract symptoms, I will counsel him about PSA as per the NICE guidelines recommendation.
What is the importance of PSA in this particular patient? Sami?
Yeah.
What is the importance of PSA measurement in this patient?
There might be an incidental findings of undiagnosed prostate cancer, which can explain his symptoms, and that will also guide me give me a prediction of his the clinical status of progression of his PBH disease, and also will guide me about his response to any future medical therapy for BB.
So how will you able to predict the progression of BPH with PSA?
The previous study, like Olmsted counter study, has found that increased PSA of a greater than 1.4 associated with disease progression, i.e. needing for surgical treatment or possibility of acute urinary retention in the future.
Okay.
With people with lower tract factors.
Any role for any other blood test in this patient?
Alongside the full blood count and baseline kidney function, and to rule out any signs of renal failure, and a PSA urine analysis, that's the basic test I will do first.
As per the NICE guidelines, the serum creatinine plus EGFR is useful only in a patient who has suspected renal impairment. If the patient has no physical signs of renal impairment, there is no need for any baseline renal function test. Okay, what other test you will do?
The urine analysis reports as I've mentioned, and free flow and a post void residual. And I will also ensure that he had a pre-filled IPSS questionnaire alongside blood diary filled at least for 3 days.
Okay, what is the role for cystoscopy in these patients?
The indication of cystoscopic examination only in patients who have risk factors such as recurrent UTI, visible hematuria, pyuria, and dysuria with profound voiding LUTS. And this is as per the NICE guidelines recommendation.
What are all the indications for imaging, like ultrasound?
Ultrasound, again, the NICE recommendations mentioned that patients with histovisible hematuria, recurrent urinary tract infection, or loin pain, or signs of kidney function deterioration, or there is evidence of clinical findings of suspected high pressure chronic retention.
What is the indication for urodynamics in this group of patients?
Normally urodynamics indication as mentioned in the AU guidelines 2022, patients who younger than 50 years old or older than 80 years old, or patients who has previously had surgical treatment with tract symptoms, patients who are unable to void greater than 800 mils with post-void residual of greater than 300 mils, and also if there is history of neuropathic elements to the lower tract symptoms, or there is any equivocal symptoms and clinical findings.
Is there any studies you are aware of which supports the use of urodynamics, or what is the result of it?
The Marcus Drake group have published a paper on the upstream trial, which has found or concluded that the performing urodynamics does not change the standard surgical practice. Hence, performing surgical treatment for lower tract symptoms does not need to be preceded by urodynamics beforehand.
Okay, so let us assume our patient does not require urodynamics. In case on a different scenario, if you are doing urodynamics, what factors you will look for?
There is patient's factors such as age, clinical comorbidities or frailty, which might predict the outcome of any surgical or medical treatment. But also in the urodynamics parameters, I will look for the bladder outflow or obstruction index, the Bowie index, and the bladder contractility index, and that will dictate or predict any potential treatment for lower tract symptoms.
So how will you calculate the bladder outlet obstruction index?
This is calculated as the detrusor pressure at Qmax minus 2 Qmax. If it is above 40, that's obstructed. Less than 20, that's normal. Between 20 and 40, that's equivocal.
Yeah, you should be able to draw the diagrams with x-axis Qmax and the y-axis p-det at Qmax. Couple of parallel lines which shows equivocal, above which is obstructed, below which is unobstructed.
Yeah.
How will you calculate the bladder contractility index?
That's the p-det at Qmax plus 5 Qmax, and again that's if it's less than 100, that's under contractile. Between 100 and 150, that's normal. Above 150, that's a strong contractility.
So again, you should be able to draw a diagram with two parallel lines, which is opposite to the Abraham-Griffiths number. Okay?
Okay.
Yeah. So for our patient, quite straightforward. So how are you going to treat him further? His IPS score is 28 out of 35 and QOL is 5 out of 6.
Okay, yeah, so he is in the severely symptomatic group as per the IPSS score. I will counsel him initially about the conservative or behavioral measures supported by the Bowels Information Leaflet about management of urinary tract symptoms conservatively. That include fluid modification, in particular cutting caffeinated beverages and switch to decaf beverages, timed voiding and ensure bladder emptying before bed, and double voiding also, and cut down on carbonated drinks. And I will, after I counsel him about that, I will arrange to see him back in clinic in about 6 to 8 weeks' time, guided by his response. I will arrange either I continue with the conservative measure or add medical treatment in forms of either alpha blockers, anticholinergic, or 5-alpha-reductase inhibitors, depends on his symptoms.
What are all the factors you will look for to decide BPH progression in a patient?
This comes from the Olmsted Plus studies, which has shown there is factors such as patient's age greater than 70, prostate size greater than 30 grams, IPSS score of greater than 7, PSA greater than 1.4, and postvoid residual greater than 50 can predict the progression of BPH in those group of patients.
Okay, so how are you going to treat your patient now?
After I counsel him about conservative measures, if that has helped, then he will be put on a period of surveillance. If the conservative measures have not worked, then I will counsel him about the next step, which is a medical treatment. And this is in form of initially alpha blockers plus or minus 5-alpha-reductase inhibitors. And if he does have elements of storage symptoms, I can add also anticholinergic to his treatment.
So how will you decide when to start 5-alpha-reductase inhibitors?
In the clinical examination has shown his prostate size around 70 cc. So I will counsel him immediately about combination therapy. And this is a form of tamsulosin and finasteride. And I will also counsel him about the dosing and the side effects accompanied with this medication.
What is the evidence for the combination treatment?
That comes from the MTOPS study and the combo data study. Both the studies have shown combination therapy reduce the risk of progression, reduce the risk of need for surgery, and reduce the risk of future acute urinary retention. Roughly, in the MTOPS study, the risk of progression has decreased by 80%, the risk of acute urinary retention and a need for surgery reduced by 60%. The combo data study shown that the risk of progression, the risk of need for surgery reduced by 60%, and the risk of acute urinary retention also somewhere around between 60 to 65% reduction.
So in which patients you will consider anticholinergics, and what is the evidence for that?
Patients with predominantly storage urinary tract symptoms can benefit from dose of anticholinergic, providing that they don't have any risk factors such as high bladder residual. This comes from the TIMES randomized controlled trial, which evaluated combination treatment with tolterodine and tamsulosin versus tamsulosin alone, and it has shown that combination therapy improved the IPSS parameters and quality of life, but not Qmax.
Okay. What other drugs possible in this group of patients?
There are drugs which have been tried in lower tract symptoms, such as PDE5 inhibitors. And normally, patients who does have lower tract symptoms with erectile dysfunction might benefit from that. However, NICE recommendation does not mention or recommend starting PDE5 inhibitors on patients with LUTS without history of erectile dysfunction.
Yeah, NICE supports starting, but it should be in a kind of randomized controlled trial, not as a uncontrolled prescription. So what type of drugs are you good for LUTS from PDE5 inhibitors?
I'm aware that the tadalafil or the Cialis has a good evidence that it helps with lower tract symptoms in ED patients.
What is the dose?
5 milligrams on a daily dosing regime, I'm aware of. Yeah.
Okay, so you are starting this patient on combination treatment. You said tamsulosin and finasteride. How are you going to further explain your regimen to him?
As per the NICE guidance recommendation, upon starting on medical treatment, I will see the patients back in about 6 months' time with a repeated flow rate, post-void residual, and IPSS score. If there is signs of improvement or response to the medical treatment, then I will subsequently see him in 6 months' time with the repeat flow rate, IPSS score, and post-void residual, and then annually after that.
So what may be the long-term complications which you have to explain to these patients?
In regards to alpha blockers, I will explain the side effects in form of posterior hypertension, dizziness, retrograde ejaculation, which are around 5 to 6%. And I will counsel him about intraoperatively floppy iris syndrome, which is around 1 to 3%. And with in regards to 5-alpha-reductase inhibitors, I will mention the side effects, which include impotence, libido, gynecomastia, and breast tenderness.
What is that intraoperative floppy iris syndrome?
This is only on patients who plan to undertake cataract surgery, for example. Taking the medications perioperatively will put them at risk of this syndrome, which had a catastrophic effect to the vision and can lead to blindness, from what I can recall.
Actually, what happens is the alpha blockers has got multiple alpha receptors throughout the body. So tamsulosin cross reacts with the alpha blockers in the iris. Normally, it doesn't matter. Even though the alpha blockers in the iris is getting blocked, we can maintain the focusing and iris can function. But in patients who are undergoing cataract surgery, where they need to remove the previous cataract material and place an intraocular lens, the ophthalmologist want the iris to have enough tone to hold the intraocular lens. In patients who are on tamsulosin, the iris will become very floppy, so they won't hold the intraocular lens. So that's the reason why we can't give tamsulosin for patients who are undergoing intraocular lens placement. Patients needs to stop maybe like 5 days or 7 days so that there is a good washout, and after placing the intraocular lens they can restart the medicines after 48 hours. There's nothing to do with like blindness or big complications. Mainly the iris tone is lost because of the alpha blocking agents in the iris itself. Okay, good. What are the long-term complications for BPE if a patient is left untreated?
If the disease has progressed, that can lead to deterioration in kidney functions, and for example, the patients can end up with high pressure chronic retention type picture, recurrent hematuria, recurrent urinary tract infections, formation of bladder stones, and deterioration in the quality of life also.
Yeah, can also cause chronic retention of urine and renal impairment. Bladder can lose its tone, gets trabeculated, diverticular formation, and can even go for atonic bladder. Okay, unfortunately, the patient which you have started the medication presented with acute urinary retention after 4 weeks in spite of taking the tablet. How are you going to treat him?
Despite the medical treatment, he went into retention. I will see him first in the clinic, talk to him about this, and perhaps counsel him about a trial without catheter, bearing in mind he's already been taking the medical treatment, just ensure that he did not have any episode of urinary tract infection or has been treated for UTI recently, and his bowel symptoms doesn't suffer from any constipation or has not undertaken any surgery recently. And I will mention to him the chances of him passing his trial without catheter somewhere around between 20 to 30%. And if he is in agreement, and I will arrange that for him in about 5 to 7 days time. If that has succeeded, then I will monitor him regularly thereafter. If that has failed, then I will talk to him about surgical treatment options for his lower tract symptoms.
Okay, in a patient who was not known to us before, not on any medications, if they presented with urinary retention, what will be your protocol?
I will rule out any possibility of urinary tract infections or constipations, ensure the patient does have an adequate kidney function test and is not in diuresis. Subsequently, I will ensure that he does take tamsulosin in the correct dosing and explain the possible side effects. And I will arrange for him a trial without catheter in a dedicated TWAC clinic in a period of 3 to 5 days time.
Do you know any evidence which supports this alpha blockers based TWAC?
This has come from the AL4 study, which studied 360 patients randomized to either placebo or alphazocin, and it was found that the success of TWAC increase in patients who take alphazocin around 60 to 62% versus 48% in the placebo arms, and has also concluded that the chance of not needing surgery has decreased if patients taking alphazocin for a minimum of 6 months.
Okay, we have not covered a little bit basic sciences questions, like for example, what is the embryologic origin of prostate?
That comes. The prostate comes from the urogenital sinus. Part of it comes from the genital sinus, and part of it comes from the mesonephric duct. Around 10 to 16 weeks. The central zone comes from the urogenital sinus, but the rest of the prostate comes from the mesonephric ducts under the effect of DHT.
Okay, what are the components of McNeil's anatomy of the prostate?
There is 4 groups. This is the peripheral zone, which accounts for 65%. The central zone, which accounts for 25%, and there is a transitional zone, which accounts for 5%, and there is an anterior fibromuscular part of the gland as well.
What are Hart's rings?
Hard rings, which is a 3 integrated, interlinked circles of BBH, BPE, and lower tract symptoms, and this is all integrated together can explain the pathology behind bladder outflow obstructions, which just reflect on how these three common things can integrate together or interlink together to explain the symptoms behind bladder outflow obstructions.
Okay, it is not BPH, it is BOO, bladder outlet obstruction. What is the significance of these rings?
It does reflect on how these three elements together can explain the symptoms and the pathology behind the lower tract symptom disease. I think my explanation is if the more they are interlinked, the higher the more symptomatic the patients are, something like that.
Yeah, it's like a bladder outlet obstruction literally means there is something which is blocking the bladder outlet, maybe very correctly diagnosed by using tests like uroflowmetry or urodynamics. Benign prostate enlargement is just a clinical finding. The BPH, what you said, benign prostatic hypertrophy, is more of a histological finding, so it's nothing to do with Hall's rings. And LUTS is the patient's symptoms. The importance of Hall's ring is one issue can be there in the absence of others. So sometimes patients can have bladder outlet obstruction without BPE, without LUTS, which means they may not be symptomatic, and urodynamically they may have bladder outlet obstruction. Those are the patients on chronicity will end up in chronic urinary retention, or they can present as high pressure chronic retention. And sometimes patients present with lower urinary tract symptoms, but they don't have any problems due to prostate. It may be due to bladder, which is overactive. That's why urodynamics may give you an idea about what may be the actual pathology. So the main idea from Hall's ring is the issues can happen on their own with some minimal overlapping possibilities. Good. Overall, nice presentation, and I'm quite happy with the quality of answers. You're able to bring some numbers here and there, and very, very small changes here and there, which you have enough time, you can easily revise and you can make it up. I'm very happy with the quality of the presentation and the speed of the presentation. You have anything to add before we complete this scenario?
No, thank you. That's that was very good discussion. Yeah, maybe just a bit of fine tuning, just be a bit more slick in this stuff that I haven't couldn't memorize. But yeah, it was very good first part. Yeah.
Very minimal. For example, just go through the NICE guidelines again. There are few new changes like NICE guidelines for this tadalafil, and no need for any upper tract imaging or even blood test EGFR unless if the patient has any obvious signs of any renal failure. Just be very confident on those things. Very good. Well done.